Hello guys, welcome to another video on syphilis, and please don't forget to like, share and subscribe my channel, and please share your thoughts in the comment section. So today we will be talking on the topic syphilis. Syphilis has many stages. The first is the primary, then secondary, then the latent and then the tertiary stage. Now the primary will progress into secondary if it's not treated. If secondary is not treated, it will progress into latent stages, the early latent, the late latent. And if you don't treat it, then finally it will land up in tertiary syphilis. So first we will look at the primary syphilis. Now just see this ulcer. This is a rounded, single, regular, well-defined edges, and it is painless and it's indurated. In primary syphilis, you are going to see such an ulcer. Now, first of all, you need to understand what is the margin, what is the edge, and what is the floor. So, this I have made a diagram of the ulcer. The margin is the junction between the normal epithelium and the ulcer. See, this is the normal epithelium, and this is the ulcer. So, this junction is the margin. And what is the edge? The edge is the area between the margin and the floor. So whenever you see an ulcer, this is the margin, this is the edge, and this is the floor. So what are you seeing in this ulcer, which is seen in primary syphilis, and what is it called? It's called a canker or a Hunterian canker and hard canker. So you may say primary syphilis, just think in your mind, canker, Hunterian canker. Now this is indurated ulcer. So when you touch it, you may feel that it's like a button. So button sign is seen in primary syphilis. The ulcer feels like a button, and these ulcers are painless. Now you may remember it like this: primary syphilis, single ulcer. Primary syphilis has single ulcer, so S for S. In primary ulcer, you are having single. Now when you will go into secondary, you will see that there are multiple ulcers. So I'm not saying that single ulcer is present in all types of syphilis, but in primary you will have a single ulcer which has regular margins and well-defined edges, and this is painless. You see, how is syphilis acquired? Syphilis is acquired when you have oral sex or vaginal sex or anal sex with an infected individual. So you may think like that when there is sex with an infected individual, so you will have such kind of ulcer which will have a buttony feel, which will be button sign, indurated ulcer, and it's painless. So this person won't have any pain if he goes and infects any other woman, because he has this ulcer, right? And it's painless. It's not preventing him from doing sex again to any other individual. So that's why it's spreading so fast. And see, the incubation period, it's 9 to 90 days. Syphilis has an incubation period of 9 to 90 days. And I have told you primary syphilis has a single ulcer. Incubation period is 9 to 90 days. It sounds similar, no? 990 syphilis and single ulcer. Now see the lymphadenopathy. This type of primary syphilis has a bilateral lymphadenopathy, and it's non-tender. See, the ulcer is also painless and the lymphadenopathy is also non-tender. That means if you touch these lymph nodes, if you press these lymph nodes, the patient won't wince in pain. So it's non-tender, and I've made a little sketch here. See, the person has got an ulcer here. So you can't say that it has a unilateral lymphadenopathy. It should be bilateral, because the ulcer is here. It's going to spread like this to other parts of the body. We'll see in secondary syphilis, if it's not treated, it will spread all over the body. So automatically your mind should think that it must be bilateral lymphadenopathy, and this is non-tender, and the lymph nodes are rubbery and shorty. Shorty means it has hard and round feel, like a pellet of shots. So it's shorty lymph nodes, rubbery lymph nodes, and bilateral lymph nodes. Let's come to secondary syphilis. If the patient of primary syphilis is not treated, it progresses to secondary syphilis. Now the skin lesions are seen here, which are bilaterally symmetrical, asymptomatic, and they are ham or rose colored. The lesions can show different morphologies, so it's called a great imitator. Great imitator, why? Because by looking at these lesions, you may be confused that is it tinea? Is it pityriasis rosea? Is it psoriasis? Your mind would be thinking so many diagnoses, so many differentials. So it's a great imitator. Now you have to ask the patient that was there any history of such an ulcer, such a primary ulcer. Now if he gives a history of such ulcers, then your diagnosis might be going towards secondary syphilis, but then you need to do the FDA, ABS, and the dark ground microscopy for the confirmation. But here you have to learn that it's a great imitator. And see, you may see all the types of lesions here, but vesicobullous lesions are never seen. Vesicobullous lesions are never seen in secondary syphilis, even though it's a great imitator. And these vesicobullous lesions will be seen in early congenital syphilis. I'll teach you later that in early congenital syphilis, the baby is having these vesicobullous lesions. So it might be a little confusing, but if you read again and again, it will be all right. So see, this is a papular syphilid. You may see many papules all over the body, papular syphilid. Now these are macular syphilid. These are macules, these are papules, and these are hyperpigmented plaques. If the syphilis infects your palms and soles, so you will see hyperpigmented plaques. Now see this Buschke-Ollendorff sign. When I am going to press these lesions with the head of the pin, the blunt end of the pin, so the patient is going to wince in pain. Now why do these lesions occur? These are mainly occurring due to vasculitis and thrombosis that is occurring. Thrombosis and vasculitis is occurring, and when we are pressing these lesions from the pin head, the patient is wincing in pain. So I made some trick here. See, Buschke-Ollendorff sign. Buschke, you must think in your mind like you are pushing the pin head. You are pushing the pin head, and the patient is wincing. Oh. The patient is wincing in pain. Now he is saying all in. So Buschke-Ollendorff sign. Wherever you read in an MCQ or in any exam, anybody asks you what's Buschke-Ollendorff sign, your mind should go towards secondary syphilis. Now I have told you, it's a great imitator. So we have seen the papular, macular lesions, the hyperpigmented plaques. Now let's see the condyloma lata. Condyloma lata, these are broad-based flat lesions. See, the base is so broad, and these are flat lesions, and these are very infective. Present over moist areas like groin and axilla. Seen due to maceration of the skin. Now what's maceration? It's softening and breaking down of the skin resulting from prolonged exposure to moisture. So condyloma lata, and these are very characteristic lesions of secondary syphilis. Lata in Latin means broad. Now you may also see these type of lesions which are moth-eared in appearance of the head. It leads to non-scarring alopecia. Now this is only non-scarring alopecia, which is seen in secondary syphilis. Now the rashes that you are seeing be pigmented. I have shown you palms and soles, these pigmented, hyperpigmented plaques. They may be scaly lesions like in psoriasiform lesions or annular lesions. There are very variety of lesions in secondary syphilis. You may also have mucosal lesions. See, in the mucosa there are erosions. So this was an erosion, this was an erosion, this was an erosion, and all these erosions have joined together to form a snail track ulcer. This is seen in secondary syphilis. These are well-defined erosions. Sometimes these erosions coalesce together to form snail track ulcers. And lymphadenopathy is seen, again bilateral, symmetrical, painless, shorty, just like primary syphilis. It's the same. But here almost all the lymph nodes have been affected because it has been spreading all over the body. So all the lymph nodes are affected. Now in older times, these sailors, what they used to do was they used to do this type of handshake, because we know if a patient has secondary syphilis, the epithelial lymph nodes, they will also get inflamed. So you may do this type of handshake and check for epitrochlear lymphadenopathy, and if there is, you may suspect that this person might be having syphilis. This epitrochlear lymphadenopathy might be seen in other cases also, but if you read this word in any MCQ, your mind should be going towards syphilis also. So sailor's handshake, in olden times they used to check. Now let's revise this secondary syphilis once again. Papular syphilis, macular syphilis, you may see these rashes, you may see hyperpigmented plaques, you may see condyloma lata, you may see moth-eaten alopecia, mucosal lesions, and lymphadenopathy. See, in primary syphilis, only there was this type of ulcer, mainly in the genital regions. In secondary syphilis also there is an ulcer in the genital regions, like this. See, not ulcer, this is condyloma lata. These are broad-based flat lesions. And then you may think also moth-eaten appearance of the alopecia, The mucosal lesions are also there, and papular lesions, macular, hyperpigmented plaques, and it's a great imitator, and vesicobullous lesions are never seen. Moving on to latent syphilis. If a person who is suffering from secondary syphilis is not treated, he is going to develop this latent syphilis. In latent syphilis, the person will have no clinical features. That's why we are saying it's latent now. But the serological test will be positive. So latent syphilis again can be divided into two: early latent and late latent. Early latent is less than 1 to 2 years, and late latent if it is occurring after more than 1 to 2 years. And what's relapsing syphilis? Relapsing syphilis means if a person is in early latent stage, he may relapse and go back to secondary syphilis. Like if a person is having this latent syphilis and his body relapses and goes back to the previous stage, this secondary syphilis stage, so then we'll say that it's relapsing syphilis. And in relapsing syphilis, you will find canker redux or monorecidive, recurrence of lesion at the site of primary canker seen in relapsing syphilis. Now what's going to happen, that first of all, relapsing syphilis, that the person who is in this early latent stage, he is going to, which is less than 1 to 2 years after primary infection, less than 1 to 2 years, he's going to develop again the secondary syphilis, and these lesions will be seen here on the site of the primary lesion, on the site of the canker. Here you will see secondary syphilis, and that will be called canker redux or monorecidive. Canker redux, relapse, you may think something like that. Monorecidive, it is receding, it is going backwards. Now finally, let's go to tertiary syphilis. If the patient in latent syphilis is not treated, he develops tertiary syphilis. Tertiary syphilis is a hypersensitivity reaction which occurs 20 to 30 years after the infections. It's going to develop very, very late. And what are you going to see in tertiary syphilis? First of all, you will see gummas. These gummas, see, it's on her forehead, and it will treat, and when you treat this, it will heal by scarring. So gamma are rubbery nodules which may ulcerate. These are rubbery nodules which may ulcerate, and they have punched out edges. What are punched out edges? See, here I told you about the ulcer, that this is the margin, this is the edge, this is the flow, this is the base. Alright. So on gamma, punched out ulcer will be seen. Punched out, you can see, it's like you have punched something on the skin, right? The edges, the margin, the floor, it's giving a feel of punched out ulcer. So this is punched out. They have punched out edges with washed leather base. The skin lesions which have late onset, these skin lesions are having very late onset. I told you that tertiary syphilis is occurring very, very late, after 20 to 30 years. See, 20 to 30 years, it's very, very late.